All right, we're recording. Share my screen. All right, so now we're going to get into distributive shock. This is video number 2, distributive shock by Kyle Ortega. All right, so what is distributive shock? It results from excessive vasodilation and the impaired distribution of blood flow. Different types like septic shock, which is a life-threatening organ dysfunction resulting from infection. SIRS, which is a systemic inflammatory response syndrome. It's basically a very, very strong inflammatory response. Anaphylactic shock, which is very popular. Hypersensitivity reaction, basically from the bronchospasm. Neurogenic shock, which occurs in any traumas, spinal cord or the brain. And then endocrine shock, so like, for instance, adrenal failure. So it's pretty much distributive shock. Physical exams findings, what we'll find when we walk to the patient's room and examine them. Altered mental state, rapid heart rate over 90, so not yet tachycardia, but we're getting there. But if they're on a beta blocker, it won't be evident. Hypotension, so low blood pressure. Tachypnea, so they're breathing pretty fast. Pulse oximetry is going to be relative hypoxemia, and then they're definitely going to have decreased urine output because there's no fluids to get off. Warm flush skin due to that vasodilation. All right, signs and symptoms of distributive shock. Um, Hallmark pretty much is that vasodilation leading to inadequate blood supply to the vital organs. Decreased vascular resistance, which impacts blood flow distribution. Um, this is often caused by severe infections, and then also, again, allergic reactions or systemic inflammation. And it's really hard to maintain that blood pressure, which means insufficient perfusion. Um, catch my voice. All right, so the imaging needed to, so that they're going to look at when it comes to diagnosing distributive shock. We're going to look at the ultrasound. It's going to help evaluate that blood flow, fluid accumulation, cardiac function, chest X-ray, just to rule out other causes of shock, such as pulmonary embolism. CT scans, it's going to reveal infections, abscesses, organ damage, echocardiography, which is using an ultrasound to get a real-time image of that heart just to see any dysfunction within it, within that myocardium. All right, so hemodynamic monitoring for distributive shock. So we're going to use that pulmonary artery catheter or Swan's gans. We're going to measure the cardiac output, pulmonary capillary wedge pressure, or the pulmonary artery pressure. We're going to use the central venous catheter to measure the CVP, the central venous pressure. Like I said, we're going to measure the arterial blood pressure. A map below 65 is where our big concern is, and it's very common with this type of shock. So with all the different kinds of distributive shock, they all have a very low or decreased CVP. There's no fluid. When you lose fluid and blood, it's going to be low. The cardiac output is going to be decreased in neurogenic and anaphylactic shock. It's going to be the cardiac output's actually going to be increased in septic just to compensate for that infection. And then pulmonary capillary wedge pressure and a systemic vascular resistance is going to be decrease. It's going to decrease in all. The lactate level is going to be elevated, which is really bad. Capillary refill time, so that's going to be prolonged just because of that impaired perfusion, impaired oxygenation of the tissues. And then the mixed venous oxygen saturation can be decreased as well. All right, so pharmacology and treatments. So pretty much how they treat this type of shock, your vasopressors like norepinephrine, want to increase that SVR because we got to help elevate that blood pressure. That blood pressure is dropped bad, and that's what we got to reverse to return to homeostasis. Inotropic agents to improve that heart pumping ability. Uh, Fluid resuscitation is a very, very important treatment when it comes to this type of shock. You want to just refill those fluids. IV fluids restore that intravascular volume, and that helps improve perfusion. Corticosteroids for inflammation, and the antibiotics if there's an infection. And then you just want to manage their patient's discomfort and pain as well. All right, so next we're going to look at arterial blood gas anomalies and mechanical ventilation when it comes to distributive um, shock. All right, so looking at the ABGs, so you're going to have a low oxygen. There's going to be hypoxia due to that reduced oxygen delivery. It's going to be metabolic acidosis due to inadequate tissue perfusion and oxygen delivery. Sorry. You're going to have low SATs, which means inadequate binding to the hemoglobin in the blood. Uh, Increased carbon dioxide for compensation, which is hyperventilation. So um, that hyperventilation plus the metabolic acidosis concurrently, the body usually compensates for acidosis by an increased in respiratory rate. All right, so next, mechanical ventilation. All right, so I know that inhaled nitric oxide can selectively dilate pulmonary vessels, improving oxygenation, may counteract excessive vasodilation in certain areas. Prone ventilation promotes uniform ventilation and perfusion, lowers atelectasis, and improves gas exchange. And then it's very helpful in severe respiratory failure. Low tidal, so with mechanical ventilation in these patients, you want low tidal volumes, moderate levels of PEEP, minimize lung injury, and maintain adequate oxygenation. Um, you probably want to keep their CO2 just a little high, um, a little elevated just to prevent that barrel trauma. So hypercapnia, we're not worried about in this situation. So next, our concerns with PPV, positive pressure ventilation. Um, our concerns include that decreasing venous return, which is a decreased preload, which is going to compromise the cardiac output and worsen hemodynamic status due to that increased thoracic pressure. Um, so we got to be careful considerations of vent parameters, fluid management, hemodynamic monitoring. So because they can contribute to increased SVR, it can exacerbate the imbalance in blood flow distribution, so just worsening the situation. And then it's crucial to avoid further compromising perfusion and cardiac function. Um, so these are the concerns with positive pressure ventilation with distributive shock. So to kind of wrap all this up, distributive shock, like I said, systemic vasodilation leads to decreased blood flow to the brain, the heart, kidneys, causing damage to vital organs. Distributive shock also leads to leakage of fluid from capillaries into the surrounding tissues. There's decreased systemic vascular resistance, an inadequate cardiac output, low central venous pressure, as well as pulmonary capillary wedge pressure. You want to use vasopressors to improve blood pressure and fluid resuscitation to address the hypovolemia. It's pretty much key in the treatment part. And then when it comes to mechanical ventilation, we want to use those protective lung strategies, protective lung ventilation to optimize oxygenation. All right, so that will wrap up distributive shock. Figure out how to stop recording. All right. Um, thank you very much.